The transcatheter aortic valve replacement process involves a multidisciplinary heart team evaluation consisting of 2 cardiac surgeons and an interventional cardiologist, along with extensive diagnostic testing and preoperative evaluation. The preoperative testing and evaluation is extremely important in selecting the correct approach and procedure for each patient. Because of the complexity of the procedure and the high-risk nature of patients undergoing it, the appropriate selection of access approach and valve size is critical to the success of the procedure. All patients are brought to a hybrid operating room, which has the capabilities of both a standard operating room as well as X-ray guidance for placement of the valve. The valve is placed through either a small incision on the side of the chest or through the groin and is done without the use of the heart-lung machine. In this patient, the access approach that was chosen is transapical, which is through the apex of the heart. Here you can see that the apex of the heart has been exposed through a small incision between the ribs, and through this access, the new valve will be placed. First, a balloon is inflated to displace the old valve and enlarge the opening to allow placement of the new valve into the aortic annulus. The new aortic valve is seen here and is then crimped onto the catheter delivery device. The valve is placed over a balloon and then crimped such that it is small enough to pass through a small opening in the catheter. Here you can see the valve in the aortic annulus. The valve is then deployed by inflating the balloon, pushing the valve out against the aortic annulus, where it is held in place with radial force. Correct placement and positioning are inspected by transesophageal echo and fluoroscopy. Patients are typically monitored overnight in the intensive care unit and have a short hospital stay.